So again, this is a typical view that we'll have once we've opened up to the back of the brain. And you can see all kinds of structures here. We have a diagram on the side to help. But this is the sella. Here are the optic nerves. This is called the planum sphenoidalis. So now we're looking at the anterior cranial fossa. Here are the carotid arteries and the cavernous sinuses. Here's the clivus. Here's the rostrum. And if we open this up and go further down, we're going to be towards foramen magnum and jugular foramen. So we now basically have a good start to approach any area of the skull base. When you open up all of this bone, this is basically what you're going to find behind it. As you go upward in the rostral, you're going to find the anterior cerebral arteries and the frontal lobes. As you go inferiorly, you're going to find the brainstem and the basilar artery. And as you go laterally, you're going to find the cavernous sinus, the carotid arteries. So just to give you a couple of examples of what we've been able to do in the past 5 to 7 years with this, we're going to start in the top and we're going to work our way to the bottom. This is a patient with a frontal sinus mass. Presented with headaches and spinal fluid leak. We basically use an expanded endonasal approach to get up to the frontal sinus and the anterior ethmoids. Here we have the image guidance identifying where the lesion was located. Here's the actual tumor when we found it. On the top are cadaver dissections showing the exact same anatomy. So right here is the cribriform plate. This on either side is what's called lamina propria, so that's the medial wall of the orbits, the eyes. Right here is where the frontal sinus is located. Way back here, that's the pituitary. So all the stuff that we were talking about before was a good distance from where we are now. But starting here, we work our way forwards to get to the anterior cranial fossa. Here we've removed a little more of the bone, and you can actually see all of the frontal sinus open there. And actually what you're looking right here is the dura of the anterior cranial fossa underneath the frontal lobes. And so right here is the actual surgical case, and you actually can see the tumor where it's obstructing the outlet to the frontal sinuses. We remove the tumor, and once we're done, here again, we now are seeing a wide open frontal sinus. Here's the dura of the anterior cranial fossa. When you do this, you might get a little bit of spinal fluid leakage, but again, you just put the glues and the replacements tissues there, and these people seal up just fine. This is kind of what the post-op image looks on this patient, and you can see that their whole cribriform plate is now gone. And you see the lamina propria, and it kind of confirms that we were actually to both sides. This patient actually did very well. What about tumors that kind of go up into the hypothalamus and to the third ventricle? These are very difficult. These are what most people say are incurable brain tumors. Well, if you start and remove a pituitary tumor here, why can't you just continue to go up? And so that's what we've now started to do. This tumor actually, when we resected it, once you're done, you actually get some great views. Here we actually have our probe in the third ventricle. And if you look very carefully, these are the white structures on the bottom there. That's the fornix at the roof of the third ventricle. And then those are the septal veins that are sitting in the middle there. So with the endoscope, we've actually been able to get to the third ventricle. We've actually gone to the middle of the brain through the nose to remove tumors now. This patient did fantastic. They ended up being in the hospital, I think, for about 5 days. They're now neurologically normal, and they haven't had any tumor recurrence in 5 years. So it was a great benefit for that patient. To give that perspective, this is the opening that we had in the sella, and we continue to advance the endoscope until we get into the third ventricle. So things are tremendously magnified, and we're probably about that far into the nose when we're doing that surgery. The other nice thing is that once you advance the endoscope, you get some beautiful views of the anatomy. Here you see the pituitary stalk. Here's the carotid artery. And you can see in the back corner in that case, you actually can see the third nerve. And the ability to see these things is wonderful because you know that you're not going to injure them if you see them. And you also know that there's no tumor on them. This is another problem child. This lady started to have double vision and balance problems, and she has this mass that's eroding through her clivus and going right into her brainstem between her pons and her medulla. She was very young. In fact, she had just had a kid about 6 months earlier, and she presented with this problem. Well, the traditional approach for that is a huge procedure where you literally are opening up half the head. It takes probably about 10 to 12 hours to get to this area. And with that approach, you're still not going to remove all of this tumor. So you say to yourself, why not just come straight back through the nose? And that's what we did. So adjusting the endoscope and just coming a little bit down, we were able to do this. So here are the cadaver correlations. When we look lower down, here's the pituitary gland. We're now looking lower. This is the clivus. The carotid arteries are on either side. And this is the nasopharynx. And this is the basically infratemporal fossa. Once you open up the bone in the dura, what you're going to see behind there is the basilar artery right here, the posterior cerebral arteries, and the brainstem. So here we are with our endoscope, using our image guidance to make sure that we are where we think we are, because this is, again, very valuable real estate. Here we are drilling out the clivus. And actually, we're debulking tumor there. This was a very fibrous tumor. Carotid arteries here, carotid arteries here. Sella is up here. We open up the base, and then once we open up the dura, there's basilar artery.
Do you remember what type of tumor it was?
This actually was a fibroma this patient had. So it was very strange. And this thing was calcified. It was one of the scariest cases I've done, because the tumor was so calcified and firm, I was actually using a drill at that location, drilling tumor off of the brainstem. It was very scary. Hopefully I'll never have to do one of those again, but the patient ended up doing fine. But again, the proof is now we're looking at the brainstem at the end of this procedure. We put a patch in there. That patient was in the hospital for 2 days. You can also start to go more lateral with these kinds of tumors. So we know where the carotid artery is. We know where the pituitary gland is. We have image guidance to tell us where the structures are. You can start to get to cavernous sinus lesions as well, which has often been considered taboo in surgery because of morbidity. Here's a lady that had a right cavernous sinus tumor. She had no other known primaries. She's developing double vision. Her symptoms were progressing. And so we said, well, we think we can get there. She had wide open sinuses, and so we thought we could get a path. And so on the top right, we actually can see the approach that we took. This is kind of the midline here, so we're off to the right. DS means diaphragma sella. So that's kind of the pituitary area. We've come to the side of it. We've exposed the carotid artery, and then we advance the endoscope through that cavity between the pituitary and the carotid to get to where the tumor was. And then once we're done, you can see here we've advanced the endoscope through it. Here's the carotid artery, and that's the medial cavernous sinus. And the patients do remarkably well from this. Her double vision did not get better immediately, but 3 months later it had completely resolved, and the patient had a fibrosarcoma. It was her tumor pathology. So as a result of being able to expose more areas, you're able to do much more. This is a multiply recurrent craniopharyngioma that we did, I think, about 4 months ago now. It had been radiated and gamma knifed. The patient was losing vision. And using microdissection technique, we're able to remove these tumors, be able to visualize all the neurostructures, and get gross total resections. This is kind of the final result of this patient who, for 15 years, had this tumor and had not been tumor-free in 15 years in spite of multiple surgeries, radiation, and gamma knife. And so for the first time, this patient was 15 years old. For the first time in their life, they were actually tumor-free. And here at the end of the case, you actually can see the carotid artery. This is actually the supraclinoidal carotid artery. It's above the cavernous sinus. You see the optic nerve, you see the third ventricle, you see all the structures, you know there's no more tumor on. And this vascularized flap heals fantastic. And it markedly decreases the likelihood of any kind of leakage. You don't need to use alloderm or any of these other foreign materials. And because it's vascularized, it's much more likely to heal and decrease leakage. And so in the very large defects, we will use these vascularized flaps to help minimize the leakage. And so we still pack it afterwards. We still put a nasal balloon in afterwards. So with this kind of approach, what kind of things can we treat? We can treat pituitary tumors, pituitary carcinomas. We can treat craniopharyngiomas, chordomas, meningiomas, hamartomas, germanomas, a multitude of different tumors. Basically any tumor that's in this region, you can approach this way. You could also treat mucoceles. You can do inflammatory pseudotumor. And then if you need just a tissue diagnosis, if you think the patient has amyloid or hemochromatosis, these approaches are very easy to get biopsies if you need to as well.